Preliminary Test 2 for NV2433 Primary Clinical Methods 1. For the preliminary test 2, we will looking at the ocular health such as Schirmer test, use of the anesthetic agent, corneal sensitivity, Bengal and Fluorescein test, tear breakup time, Jones test, lead eversion, Exophthalmometry, IOP screening or intraocular pressure screening, color vision screening, and also visual field screening. Schirmer test is to evaluate the integrity of lacrimal secretion system. We have Schirmer 1 and Schirmer 2 test, which is Schirmer 1 is to measure the amount of total tear secretion within 5-minute periods. And the total secretion actually refer to the sum of basal secretion and reflex secretion. To test the Schirmer 2 test, or we can refer as a basic lacrimal test, we need to eliminate the reflex secretion. So in the Schirmer 2 test, a topical anesthetic is used to eliminate reflex secretion. So only the amount of basal secretion within 5-minute period is measured. Schirmer test procedure. We have two tests here, which is Schirmer 1 and Schirmer 2. For the equipment, we need to have Schirmer test strip and also topical anesthetic. And in the same time, we need to have PD ruler, which is in millimeter ruler. And if you have the Schirmer test strip with the millimeter scale, so we no need to use the PD ruler. Set up. Before removing the Schirmer strip from their cellophane wrap, fold the rounded end of the strip so there will be crest at the notch. Remove the strip from the cellophane wrap, taking care not to touch the rounded end. Dim the room illumination and perform the test with the patient in the upright seated position. For the Schirmer 1 test, instruct the patient to look up. Gently pull the lower lid of the right eye. Place the folded notch end of Schirmer strip over the lower lid margin and its lateral third. Avoid touching the cornea with the Schirmer strip. Insert the second Schirmer strip in the left eye in the same manner. Instruct the patient to keep his eye open and continue to look up. He may blink freely, although excessive blinking may result in significant reflex tearing. Remove the Schirmer test strip after 5 minutes unless the entire strip wet before the end of the time period. Mark the wet portion of the strip. Measure the amount of wetting from the notch in millimeters. For the second or Schirmer 2 test, first of all, you need to instill 1 drop of topical anesthetic in each eye of the patient eyes. Wait for the reactive hyperemia and reflex tearing to subside. And then repeat the step in Schirmer 1 test. This is an example for the recording. Schirmer 1 test, right eye 30 millimeters within 4 minutes. And left eye 25 millimeter over 5 minutes. Schirmer 2 test, 12 millimeter 5 minutes. Left eye 10 millimeters over 5 minutes. Installation of eye drop, which is anesthetic agent or any other eye drop. Please refer to the eye folio how to do the installation of the drops. Corneal sensitivity test. We have two methods to do the test, which is either qualitative or quantitative. For the first one is qualitative, which is used by poking the cornea with a small filament of cotton wool. Please refer the eye folio. I have uploaded the video how to do this test. For the sensitivity grading, we have 4 scale here or 4 grade here, 1, 2, 3 and 4. For the 1 and 2, it is normal and 3 and 4 is abnormal. For the quantitative technique, we use the anesthesiometer to determine the corneal sensitivity. And picture shows that how we use the anesthesiometer, which is the procedure is the same like the qualitative technique, which is the probe will touch the cornea, and the very sensitive cornea need long probe, and the less sensitive cornea need shorter probe. And we will record the finding by milligram per square millimeter. The corneal sensitivity is depending on the location of the test. This is because position of sensitivity is vary according to the area. For example, sensitivity of cornea will be increased at the center, horizontal, and also lower cornea. Because of that, if you do the test for the corneal sensitivity, make sure that the area you test on the right eye is the same with the left eye. Bengal and fluorescence test. It used to evaluate the integrity of the cornea or conjunctiva epithelium. Normally, we use with the slit lamp for evaluation of the cornea assessment. However, if you don't have the slit lamp, you can use the button lamp. Please go and find out what is the difference between Bengal versus fluorescent. This is an example of the Bengal and fluorescent strip. So the red one will be Bengal and the fluorescent strip will be the yellow one. Bengal was made by Gnem in 1982 and was used as a corneal stain in 1914 by Romer, Cap and Lohlin. In 1933, Sjögren described the use of Bengal for revealing corneal abnormalities and abnormal tear film with keratoconjunctivitis sisca. Bengal clinically used to detect death or degenerative tissue on the cornea and the conjunctiva. Bengal selectively stain on devitalized cell, and it can be used to help diagnose keratitis sisca, hepatic eye disease, epithelial keratitis, filamentary keratitis, and also exposure keratitis. Bengal stain cell a light bluish red, severely degenerate cell appear dark red, and deaf cell become an intense red. The intensity of the color made it easy to identify the devitalized cell of both the cornea and conjunctiva epithelium. And we can view the staining using the white light. This is an example of the Bengal on staining ocular surface, which is on the cornea, inferior cornea. You can see the red staining on the inferior of the cornea. And the second picture is Bengal staining of mucus, debris, and devitalized epithelial cells is observed in the inferior cornea and bulbar conjunctiva of a patient with Sjögren's syndrome. This is another example of the Bengal staining, which is on the patient with the hepatic dendrite at the inferior of the cornea. This is another picture, which is Bengal staining on the patient with the hyperthyroidism, which is the bulging eye. Bengal normally main use when suspecting severe dry eye disease, and sometimes used to see corneal desiccation caused by the lagophthalmos, facial nerve palsy, entropion, exophthalmos, and also ptosis surgery. It helps in filamentary keratitis, stain desiccated epithelial cell and mucus that are attached to the cornea. For the hypersymplex keratitis, Bengal will stain brightly stains the damaged epithelial cells on the ulcer border, so it's easier to diagnose patients with hypersymplex keratitis. And sometimes a lesion will not stain with fluorescent, but will with Bengal because the epithelial lesion has healed but the devitalized cells are still present. Fluorescein, made by Bayer in 1871 and used in 1882 and 1888 for epithelial defect and in the anterior chamber by Fluger and also stroke. In 1910, Burt used it to detect the retina disease. Fluorescein applied topically for the clinical, it helped to detect break in the corneal epithelium, punctate epithelial erosion, aberration, ulcers, foreign body, tree breakup time, and also sedal sign. We also use fluorescein for other clinical, such as in contact lens, which is management of contact lens, evaluation of the lacrimal system, which is we can use it in Jones dye test 1 and 2, and also application tonometry, which is Goldman tonometry. Under the white light, the fluorescent will look yellow-orange, and under the cobalt blue, it fluoresces to produce a green-yellow light. Fluorescence is ability of certain substance to absorb light of certain wavelengths and emit light at longer wavelength. And normally for fluorescent assessment, we use the cobalt blue to see the effect of the fluorescent. This is what we can see, the fluorescent with the white light, which is we can see the yellow. And when we use the cobalt blue, we will see the green-yellow light on the cornea. How it works, fluorescent cannot penetrate the cell membranes of the epithelial cell because of the tight junction between epithelial cells, but it shows break in the cellular space. With the epithelial loss, the dye can spread into the stroma tissue and even enter the anterior chamber where it appears as a green aqueous flare. And clinical interpretation of fluorescent staining, a wide range of disease will produce various fluorescent staining pattern. It depends on the disease or the cause of the disease. Here are a few examples. For diffuse staining, is because of the bacterial viral conjunctivitis and also probably because of the allergic keratoconjunctivitis. And if the staining is upper 1/3 stain, then it is characteristic of certain disease such as trachoma. Interpalpebral staining is exposure of conjunctivitis, UV lower 2/3, staphylophoma, blepharitis, entropion, and also exposure keratitis. For the linear streak staining is a mechanical aberration, trichosis, entropion, and also foreign body. And sectoral staining is because of the trichosis and also trauma. And it also can detect the dendritic staining, which is because of the herpes simplex. This is staining using the fluorescent. We can see the severity of the staining on the center of the cornea. Alright, the first one is no staining on the center, it's only superior part. The second picture shows that there is some staining on the central of the cornea, and the third picture shows that diffuse staining all over the cornea. This is one example of the staining because of the extropion, but the picture is not really clear here. But the senile entropion, we can see the staining on the cornea because of the entropion. Tear breakup time, or the short form will be TBUT. This is to measure the stability of the film. It's very important to see the lacrimal insufficiency and also a baseline TBUT in the contact lens fitting. We need to use the biomicroscope, sodium fluorescent strip, and saline to identify or to determine the tear breakup time. But if you don't have the biomicroscope, we can use the button lamp. And please refer to the iFolio. I have uploaded the video how to do the tear breakup time. To determine the TBUT, you need to understand the structure of the tear film, which is the tear film has three main layers, which is outer lipid layer, middle aqueous layer, and also inner mucin layer. And the lipid and mucin layers serve as the aqueous layer protection from evaporation, therefore keeping the eye moist and hydrated. So the problem with the lipid amusing layers will result in the aqueous layer evaporating, the precorneal tear film will dry out and the patient will complain of dry, red and burning sensation. If the aqueous problem normally decrease in tear production, which is lacrimal gland problem, will also cause dry eye complaint. When you see staining on the cornea with the fluorescein, dry areas will appear as black spot or streaks against a solid green glow. The amount of the time it takes for dry area to form in the stained tears layer following a blink is known as the tear breakup time or TBUT. Normally, time elapsed before a black spot or dry area appears is about 15 seconds. A greatly reduced TBUT is indicative of dry eye disease, which is less than 10 seconds is considered reduced. However, please go and find a journal from Nohani Muhyiddin about the dry eye among ASEAN population. Please perform TBUT during your slit lamp examination when the history indicates a need for it based on complaint. TBUT should be performed prior to installation of any topical anesthetic or dilating agent. If patients have problem refraining from blinking, hold their lid. And the area the fluorescent strip touch, which is bulbar conjunctiva, will stain brightly, but do not worry about this. Do not instill fluorescent in a patient that is wearing soft contact lens. This is because soft contact lens can absorb the stain, and this dye can stain on the soft contact lens, so rinse out patient's eye before reinserting contact lens. Special dyes made for patients with soft contact lens, which is we call it as a Fluoresoft, and we can use the fluorescent with the hard contact lens because hard contact lens will not absorb the stain. Counting tear breakup time. Align patient on the slit lamp or in front of the butter lamp. Introduce cobalt blue filter, check for corneal integrity. Instruct patient, take a nice hard blink and then hold your eyes open for as long as you can. Always be scanning the entire cornea. Count seconds in your head until the first black streak area appears. Jones test. We have three types of the Jones test, right, to determine the patency of the lacrimal accessory system. For the demo methods, please refer the textbook by the Carlson. And lid eversion is to allow observation of the palpebral conjunctiva of the upper eyelid. I have uploaded video how to do the lid eversion. Please refer to the iFolio. Exophthalmometry is to measure the position of the eyeball in the orbit to rule out proptosis or protrusion or recession of the eye relative to the orbital structure. For the demo, I think I have showed you the demo last lab session, so please refer the last lab session. Expected finding, please find out what is the expected finding, especially for the ASEAN population. There is a latest journal about the normal value for the exophthalmometry. This is a non-contact tonometer, which is to measure intraocular pressure. And the method used is the cornea is aplaned by an A pump and IOP is measured without direct contact to the cornea. So I will show the demo when we have the lab session next week. For color vision screening, we have a lot of color vision tests, but for the screening, we use the Ishihara test. And for purpose, method, and also the procedure, please refer to the textbook by Carlson. And I also have uploaded the video. Please have a look in iFolio. Visual field screening. to screen for previously unnoted visual field defect. Okay. Method used is finger counting, or we can call it as a confrontation test. And expected finding will be full for the right eye and the left eye. Recording either full or any restricted of the visual field. You need to write down where is the restricted area of the visual field. And for the procedure, please refer to the textbook by Carlson. And I also have uploaded the video in the iFolio. For the practical session, please refer to the lab manual and also refer to the textbook by Grosvenor and also Carlson. Thank you so much.